Okay, are we back?
Yes.
Yes, ma'am.
Can you see Module 12?
Yes, ma'am.
Oh, okay. By golly, I think I'm getting it. All right, let's kind of just put on a different hat now, and we're going to be looking at our periodontal probes. Now we're getting into the specific instruments. The modified pen grasp is something that hopefully you're working with. You picked up your periodontal probe and tried to do something with it on Monday and went, ah, what's going on? So let's take a look. Ideally, what we do is we go over this prior to what you have in clinic. So we're still trying to work on working ahead a little bit. We're catching up. But there are a lot of different probes out there, and there's a working end that's blunt and it's rod shaped. It's cross section. It can be circular or rectangular because there are different probes out there, and they're calibrated with millimeter markings, and each style of probe has different millimeter markings. What the probe is designed to do is help collect data from an examination that's used to determine the health of periodontal tissues. Probes are used like little rulers for making intraoral measurements. So it's not just for measuring between the gum and the tooth. If there's a lesion inside the mouth or on the lip, we are measuring that lesion with the periodontal probe. We can measure the sulcus and the pocket depths. Now, the difference between a sulcus and a pocket is one is healthy and one is not. A sulcus is healthy. If it's not healthy, it is a pocket. You measure the clinical attachment levels. So you're taking all of your readings and doing some math calculations. You're determining the width of the attached gingiva, because again, we want that nice thick zone of attachment where all those periodontal ligaments are. We assess for the presence of bleeding. If we're placing something between the gum and the tooth and it bleeds, we can make the determination or the assumption that the lining of that sulcular epithelium is not healthy. We can measure the size of lesions, and we can measure longitudinal response of periodontium to treatment. So what that statement's saying is we have a comparison from one visit to the next, to the next, to the next. This is where you were 5 years ago. This is where you are today. That's that longitudinal response. So let's take a look at the different types of probes. Marked off in millimeters, again, used to evaluate the health status of periodontal tissues. Look at how many little lines there are. I see this and I freak out because it's like, oh my gosh, how am I supposed to know that this is 15? You get familiar with your probes. It's important that this office same probe in operatory to operatory. It makes the readings more calibrated, and it allows you as the clinician to not have to think about it because you are going to get to know your probe. This is, that's a very popular probe, but you need to know what the millimeter markings are. So the working end is marked off in millimeter increments, and depending on the type of probe you have will depend on how you're reading it. So you can't assume that all probes have the same pattern of millimeter reading. So you need to know what probe you have. So this is a UNC 15. We have markings at 1, 2, 3, then 4, 5 is a band of black, 6, 7, 8, then 9, then 9 and 10 is a band, and it goes all the way up to 15. It's a very precise probe. Versus this is a Williams marking probe. 1, 2, 3, 4 is missing, then 5, 6 is missing, 7, 8, 9, okay? This is called a color-coded probe or a marquee probe. They are color bands, 3, 6, 9. So you're taking your best guesstimate if the gum tissue is here. Is this a 2? Okay, it's closer to a 2 than a 3. If the gum tissue's up here, it's a 3. If it's up here, it's a 5. So these give you a little more judgment call. When a probe is inserted into a healthy sulcus, we like to see 1, 2, 3 millimeters with no bleeding. You can see that this probe is difficult to see because there aren't any little black marks in here. This is the 5, the 3, the 2. So this is a 1 millimeter right there. Probing deeper than 3 millimeters can indicate periodontal disease. Look how far down this probe is sinking. There are computer-assisted probe. The Florida probe has been out for a number of years now. I've never worked with this firsthand. I've seen it in meetings. There's a little sliding scale here, so you place the probe in and then it kind of goes in like that, and then the computer will mark it for you. They also have things that are foot controlled. One's called the RAT system by a dental hygienist, and you're tapping things with your foot. So our computer systems will do this, but we have to put the numbers in, versus in the Florida probe, it does it already. You've seen pictures like this before. Let's take a look at this tissue. Does this look like it's a healthy mouth? Color, contour, consistency, embrasure space. How would you describe it? Just think about the words you'd use. Look at the difference between the maxillary gingiva and the mandibular gingiva. Can you see where that mandibular anterior is glossy and shiny, loss of stippling? So this might be a little bit of inflammation, don't know. But just by looking at the picture, that's what I'm thinking. Where is that zone of attachment? You can see for the maxillary, this zone of attachment, very thick. So you're measuring from the gingival margin to the mucogingival line, and that's your MG, it's called, on the Dentrix computer, and you're putting, this is probably 8, 8, 6, and then here it's going to be, 4, 4, 4, and then 3's in the back here. So we've got a generalization on what to expect around a tooth. So when you're calling out numbers, you can raise our eyebrows if we're hearing something really weird. But the tooth gingiva surrounds the neck of the tooth like a turtleneck. The V-shaped space between the free gingiva and the tooth surface is called the sulcus, the gingival crevice. And this is where we place the probe. This is your junctional epithelium. The junctional epithelium is the tissue that forms the base of the sulcus. The sulcus is defined as the distance from the gingival margin to the coronal most part of the junctional epithelium. The gingival margin to the coronal most part of the junctional epithelium, and this would be the apical part of the junctional epithelium. Does that make sense? Interdental papilla, interdental, fills the space between two teeth. The attached gingiva is the part of the gingiva that is tightly connected to the cementum of the root and has connective tissue. Now, a gingival pocket is a gingival sulcus that's been deepened by disease. So it's generally greater than 3 millimeters. 1s, 2s, and 3s are considered normal. Anything above 3 may be considered disease. This is what you get used to telling your patients. But anything that is greater than 3 millimeters may be a pocket. So you've got a gingival pocket and a periodontal pocket. A gingival pocket is the gingivitis stage of inflammation. The gingival sulcus is deepening because the tissue is puffy and swollen. There's no junctional epithelium migration. Versus a periodontal pocket forms when there's apical migration of the junctional epithelium and destruction of periodontal fibers and bone. When this happens, it is irreversible. Apical migration of the junctional epithelium and destruction of the periodontal fibers. You don't have that with the gingival pocket, you just have swelling. A probe's inserted into the periodontal pocket. This is reading 6 millimeters. I have to take their word for it because I don't know what that probe is. You have one of these yellow probes in your Q-Fruity packet. We save it for implants, but you don't have to use it just for implants. Instructors, we went to this when it first came out, and the instructors hated it because what happens is this plastic will bend, and it bends because you're placing too much pressure on it. So instructors didn't like it. I don't like it, not because it bends, but because it's thicker than the standard probe. And if you've got a fat cone trying to get into a tight space, it's not going to get in as easily as if you have a small cone. So you're measuring the distance in millimeters from the gingival margin to the base of that sulcus or pocket. And that's what it looks like. With the pocket, it's going down further. So this is the 3 millimeter mark here. You'd be reading this as probably a 2 millimeter area. This is the 3 millimeter here. So this would be a 4 or maybe even a 5 millimeter area. Healthy, 1 to 3. These are just guidelines, 1 to 3. Can you have a healthy 5 millimeter area? Yes, you can. Do we like seeing it? No, we don't, because it's more difficult to take care of. But in generality, in disease, probing depths are greater than 3 millimeters, but it's not an absolute. So for our probing, you're going to be walking the tip of the probe along the base of the sulcus for the purpose of assessing the health status of the periodontal tissues. You're using the side tip of the 1 to 2 millimeter side of the probe, the side tip. You want that probe to be kept on that tooth surface at all times. Otherwise, you're probing air. Okay, this is not a probe reading. This is that height of contour of the tooth, the big fat portion of the tooth on the cervical third of the tooth. So this probe needs to be angled to get along that bump. So we talk about parallel to the long axis of the tooth all the time. The probe or the working end is positioned as parallel as possible to the root surface. So you have to kind of envision what that root surface is going to look like underneath the gum and the bone. The probe must be parallel to the mesial distal dimension and the facial lingual dimension. So this, remember that other picture where it was probing air because the probe was too straight? This is keeping that probe parallel. That is not parallel. And once you get it underneath the gum tissue, you're making walking strokes. This is the stroke that you're going to be using for all of your instruments, be it exploring, scalers, curettes, whatever. You're walking that instrument. And that's a series of bobbing strokes that are made within the sulcus or pocket while keeping the probe against the tooth and in alignment with the root surface, all while your fingers are together and you've got a proper grasp. We're not, it will come, but you're keeping this probe within the sulcus and you're just making tiny little movements forward. You're not coming out and going back in and coming out and going back in. Walking strokes are used to cover the entire circumference of the sulcus. The junctional epithelium is not always uniform. It doesn't go across a straight line, so it's important that you make tiny little walks. So you're going to insert the probe lightly and run the tip along the tooth surface until it encounters that soft base of the sulcus or the pocket. That junctional epithelium that forms the base will feel soft and flexible when it's touched with the periodontal probe. You create a walking stroke by moving the probe up and down in short bobbing strokes, keeping it in the sulcus, moving it about 1 millimeter at a time. You don't remove the probe from the sulcus each time because that's going to traumatize the tissue. Now, the amount of pressure that should be exerted on a probe is 10 grams to 20 grams of pressure. And we'll get, like I said, the scale out next week so you can feel how light 20 grams of pressure really is, okay? But it's very light pressure. Otherwise, you're going to be poking the gum tissue, and poking the gum tissue with too much force is going to make it bleed, even though it's healthy. So you're bobbing along the soft tissue, walking along the whole tooth to cover the entire circumference of the tooth. Because look at how some of the depths might change with the bone. We can't assume that it's going to go in a straight line. So you're going to be walking around 2, 2, 2, 2, 4, 2, 2, 2, and you're going to discover that there is some attachment loss here. If you don't know that when you're using your scalers and curettes, you're just going to be missing this area completely. Walk around the entire circumference. You're going to be measuring 6 measurements on each tooth. Zone 1, 2, 3, 4, 5, and 6. Mesial, straight buccal, distal. Okay, or however you want, and then the lingual, the same thing. You've got a straight buccal and a straight lingual. So these are the straights, and these are your line angles. The distal, this would be the distal lingual line angle, all right? The distal buccal line angle. You take for whatever that is it zone 1, 2, 3, is this the straight buccal, or is it at a line angle? Is it going to the mesial or towards the distal line angle? So this would be part of that straight buccal reading. So you're having 2, 2, 5 for your readings here on this probe. That reading C is going to be the one that you write down for that whole straight buccal. So there's 6 areas that you probe. You record 1 reading or the deepest reading per zone, and you round up to the next fullest millimeter. So if it's about 3.5, you're putting 4. Various factors can affect the accuracy of measurements. The position of the gingival margin. Is there gingival overgrowth? Is it well above the CEJ? Is there recession? Is there any interference from calculus or other rough overhanging restorations? Are the teeth crowded together? The mandibular anterior, can you even get interproximally? How much pressure are you applying as the clinician? And are you reading the probe correctly? So when two teeth are in contact, they're side by side, and there's a special technique that's used to probe the area directly beneath that contact area to reach the center of that caul. Because it's impossible to probe the base of the sulcus that's directly underneath the contact. You've got another tooth in the way. So you have to angle it. So what you're going to do is a two-step process. You're going to walk the probe between the teeth until it touches the contact area. You can't go in any further. Then you're going to angle the probe a little bit more, slightly, so that it reaches underneath that contact area. You press down a little bit, okay, because you're trying to get this tip of the probe right here in the center. And then when you're doing the lingual, it's going to come on the other side this way. So you angle it, you press down a little bit, and then what you want to do is then bring it back up to make sure that this is as angled straight as possible. If you just go in straight, you're missing that caul. But can you see what we're trying to get at here? Maxillary molars, when you're doing the maxilla, the mandibular teeth get in the way. So for this, what you do is you reposition the instrument and you bring the handle to the side of the patient's face. And that gives you maneuverability to get to the distal of those molars. This is why it's important to have your textbook with you in clinic, because when the instructor is busy doing something with another student, you've got your book, at least you can help troubleshoot the two of you together. So you're going to look at me, my patient, my light, my grasp, my finger, my rest, and application. Zone 1, you always start in the most distal portion of the tooth. So you start from the distal and work mesially. So you go from the distal line angle and you walk distally. Keep the tip in contact with the tooth, pressing down. Okay, initiate the short bobbing strokes towards the distal, so you're walking it distally till it touches the contact. Then you're angling it just a little bit more, gently pressing down and making sure that your probe is against that contact. So this is what it looks like if you don't have a tooth next to it. Then prepare to access zone 2, which is the straight facial, from the distal facial, and you go all the way to the mesiofacial. So what you do is you can either take the probe out and reinsert it, or you can, without it being dragged against that junctional epithelium, you can slide it back over here. I take it out and reinsert. That's my thing. Both are correct. Then you go from the distal line angle all the way around. You don't take the instrument out when you're starting to do from the mesial line angle in. You just start angling the probe. And the probe should stay in. This says reinsert, but you don't reinsert.
Ms. D, I just have a quick question that so when we probing, doing let's see, the facial towards you or the facial away you, does it matter, or you just sit on the right clock position and then you walk through all the surface of the buccal facial or the lingual facial or the lingual yes, facial or something like that?
You're going to be sliding your saddle around to maintain neutral positioning. You're not using any working stroke. You don't need strength behind you. So as long as you're maintaining neutrality, there's a little bit of flexibility there.
Mm-hmm.
I go from the 9 o'clock to the 12 o'clock position, and I don't even realize I'm doing it. So it's not static. You're going to be moving. You're not going to be in one place.
Okay, all right, it makes sense. Thank you very much.
Anterior teeth. Look at this maxillary canine. It's a very curvy tooth. This is having you insert at the distal-facial line angle. Walk towards the distal. Tilt the probe to take the distal reading. Reinsert. Go all the way around. And then continue going to take your mesial. Those are your 3 readings. Me, my patient, my light, my finger rest, my adaptation. Informed consent. People have the right to full disclosure of all relevant information so they can make informed choices about their care. What we're doing is we're collecting the data, we're getting together everything to create a treatment, a diagnosis and treatment plan. Then we present it, or the dentist presents it to the patient. They make the decision whether or not they're going to accept treatment, either all of it or some of it. It's informed consent. So you as the dental hygienist provides the complete and comprehensive information about the recommended plan for periodontal implementation and instrumentation. Your dentist is going to be relying on you to do this, depending on the protocols, but the patient needs to make a well-informed decision about accepting or rejecting your proposed treatment, because it's their right to say no thank you. It also includes the possibility of risks and unanticipated outcomes of treatment as well. What would some of the unanticipated outcomes be that the patient wasn't expecting? You remove all that calculus that's binding the tooth together, the teeth might become mobile. The tissue, that calculus that's been covering that tooth and root surface, is taken off. Those teeth might be sensitive. So now you've got mobility and sensitivity that the patient didn't have before you did all their work. They're not happy. You have to try and allow them to know what's going to come up, what might come up, and that we've got a plan for this in case it does. Here's your Sensodyne toothpaste. Here's your fluoride. Let's do a fluoride varnish after each of your scalings, that type of thing. But informed consent, they need to have the reasoning and the importance of the proposed treatment. We are not berating them with it. This is what you're presenting with. These are the various things that we can do to help resolve, reverse, whatever, all right? And we usually will have option A or option B, and option C is always doing nothing. Okay, we give them, we'd love to do this, 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 and this, and put in implants and do this and that, or, you know, we can just do this, or we can do nothing. What are the risks involved? The risks involved is always losing teeth. All right, if nothing is done, that's the ultimate risk. The possible unexpected results, mobility, sensitivity, periodontal infections, abscesses, because we didn't do a complete and thorough debridement of that area. Alternate approaches to treatment. You know, we can apply Arrestin, which is an antibacterial agent underneath the gum tissue. We can do laser. We can do, you know, what are some of the other approaches? You'll have patients wanting to put tea tree oil underneath their gum tissues, and they swear by it. Okay, as long as it's not doing any harm. What are some of the possible consequences of refusal of treatment? You're not going to get better. We don't know how long you're going to be able to hold like this. It might be 6 months, it might be 6 years, it might be the rest of your life. We don't know. We don't have the crystal ball. What are the costs of the treatment? And that's always what the patient wants to know. Will insurance cover it? What is my responsibility financially for this? Because unfortunately, that might be their determining factor. What is the patient's capability of consent? Do they understand what you're telling them so that when they sign their treatment plan, they actually understand? So you might need an interpreter. You might need a guardian. And the patient has to sign the treatment plan for it to be legal. So we've got a verbal consent, and a verbal consent or implied consent, just by the patient being there, that is implied consent, that they're going to let you look at their teeth and take x-rays and whatever. But that's not really as legally sound as a written consent. And a written consent is that treatment plan that's signed by the patient in the patient's chart. Just like the new patient forms, you've got your medical history, you've got your HIPAA form, you've got all of these forms that the patient signs. That is showing legally that they've had the opportunity to look, to read, and to ask questions. There's also informed refusal. I don't wanna. The patient may refuse the proposed treatment. And that is a touchy situation. Specific treatments may be refused by the patient. I don't want any x-rays. I don't want fluoride. I don't want. We've had patients refuse periodontal probings, and they didn't want to know. I just want my teeth cleaned. You need to document everything carefully, include the refusal form. My office had a refusal form that the patient actually signed. I was explained the risks of not having this done, and I accept the risks. Legally, that's the touchy situation. Is it really going to hold up in court if that patient decides to sue you? And the answer is typically no. What it's called is a jury of your peers. Mrs. Smith refuses to have radiographs taken, and she comes in and she has a tooth that has decay that was not noticed because it was underneath the restoration. The tooth needs to have a root canal and this and that. And she's upset because you, the general dentist, didn't diagnose it properly. Well, you were allowing her not to have x-rays taken. So if this goes to court, then the court system has a jury of their peers where they would ask 12 dentists, for example, would you need an x-ray to properly diagnose this? And if they said yes, then that dentist is found liable. So allowing the patient to dictate the treatment they receive for the diagnostic capabilities is really touchy. Now, allowing them to say, no, I don't want this, after they know that there's decay underneath the filling, that's something different. Color-coded probes, all sorts of different color-coded probes, 3, 6, 9, 12. This is my marquee probe. I love this probe. The metal ones are thin. It's almost like a needle. It's so thin. You can get into the tightest areas with a thin probe than you can with a fat probe. So what's the probing depth here?
Six millimeters.
Yep, 3, 6. So it's going in the wrong direction. It's 6 millimeters. What's the probing depth?
3 millimeters.
3 millimeters. Yep. What's the probing depth? 3, 6,
9.
9 millimeters. So we had a 3 millimeter, a 6 millimeter, and a 9 millimeter probing. So do probing depths alone really provide accurate information about the amount of bone loss? And the answer is no. And I think I just lost a picture. Anyway, because if I go back, hold on, let me go all the way back here. Look at where the bone is. Look at where the bone is. So you can see that the probing depth alone doesn't give us the picture we need of what's going on in the mouth. We need to know, where is that gum tissue? Is it at the CEJ? Is there hidden recession? This is what we call hidden recession. There's recession here, so they've lost 3 millimeters of gum tissue. They've got a 3 millimeter reading. And years ago, and some offices still do this, they're just taking the probe readings. They're not considering where that gingival margin is. And it's infuriating, because it looks like a very, this if I saw this on paper, oh, that's healthy. 3 millimeters, great. 9 millimeters, oh my gosh. Bone levels at the same area. And I need to figure out how to get back to my desktop. We've got one more module. Could we refuse the service if they do? Oh, yes, absolutely. The risk management courses that you all will be taking once you get your license is, it tells you to dismiss that patient from your practice, because you are opening yourself up for liability. So that's the touchy situation. You know, how long do you allow Mrs. Jones to say, I don't want radiographs? And there comes a time when you have to put the instruments down and say, if you don't allow us to do what we need to do the next time, you'll have, I didn't mean to do that. They'll sometimes have to find another dentist.
Miss T, I just have a quick question.
Mm-hmm.
Yeah, so back on the slide, on the tooth B, I see that the gum line defect below the CHE. So when we probing, so we record the millimeter that we see under the sulcus, or we record from the CEJ until we meet the sulcus? What is the
You're
distance that we
recording
record?
all of it. You're recording all of it. Who am I talking to? Is this Hua?
Yes.
Oh, okay. I'm trying to put names and faces and voices, and it's going to take me 2 years
I'm
at the rate
sorry.
I'm going. No, it's you're recording the pocket depth. That's the PD. Okay, and all this is going into the computer. So you do all the PD first. So that's your 323, 323. That's the gingival margin to the mucogingival line.
Mhm.
Then there's another measurement that measures where is the gingival margin. And if it's all around the CEJ, you don't need to put in anything.
Oh,
That's your neutral position. The computer will do that. But if it's above the gum, if the gum tissue is above the CEJ significantly or below the CEJ, you write that number in.
oh,
You
so
take that into account. Then you're measuring also, what you're doing is measuring the clinical attachment level, where you have to do the math as far as where's the gingival margin in relation to that junctional epithelium
yes.
and everything. So that's all taken into consideration.
Okay, so there should be 2 different records if we do
Oh,
the
many different records. Yeah,
Okay.
it's all on the same record, but you're measuring like 4 different things.
Okay, that makes sense. All right, thank you very much.
And I am having a brain fart here. I can't find my controls to share screen. There it is. Can you see my screen?
Yes.
Explorers, thank you. Okay, let's go over explorers. We're going to be looking at this next week. The function of explorers and the designs. This is your ODU Explorer. It's an assessment instrument, so what color are your assessment instruments banded with? Pink. Yes, you're pink. All right, it's an assessment instrument with a flexible wire-like working end, and it's used to detect subgingival calculus deposits as well as anatomic features. It's used to examine the tooth surface for calculus deposits, dental anomalies, anatomic features of the teeth, as well as assess dental restorations and sealants. So you're feeling on top of the gum line and underneath the gum line with this instrument. So if you're feeling on top of the gum line, the instrument is used coronal to or above the gingival margin for supragingival instrumentation. If you're feeling it underneath the gum line or beneath the gum line or the gingival margin, it is subgingival instrumentation. It's a thin, flexible metal. What this does is this part's next to the tooth surface or the root, and it conducts vibrations that go all the way up into the working end, all right, into your fingers. So you are going to be interpreting what you're feeling. So the tip millimeter, 1 to 2 millimeters, the side tip of that explorer is what is being adapted to the tooth surface. The side tip, just like the probe, side tip, 1 to 2 millimeters. This is a different type of probe here. Side tip. This particular one is ideal for subgingival use. You don't use the point, you're using this whole area here. So you've got two different probes. You've got your ODU 1112, which is the one that's got all the angles. Then you've got your 2317. This is the 17 end of the 23. So they're available in a lot of different designs. Pigtail, cowhorn, Orban, 1112 type. This is the pigtail, and it's named because this resembles the tail of a pig or a bull's horn. So it's pigtail or cowhorn, depending on what school you went to. This was what we had, because they hadn't invented the 1112 yet. But look how big this is. This really distends the tissue when you're trying to work with it. But it's used for calculus in normal or shallow pockets, okay, because it's so big and it's thick too. This is the 17 end of the 2317. It's got a 90-degree tip with a straight lower shank. This is the lower shank here. It's good for subgingival calculus on the anterior areas, on the straight facial, the mesial, the distal, the lingual. For anterior, it gets into those long, narrow pockets. So the back of the tip and not the point is directed at the soft tissue. This is against the soft tissue and not the point. And we're going to show you that next week. The straight shank makes it difficult to use in posterior teeth. So they've come up with this ODU 1112 design, and it's got a lot of bends to it and curves. It's got a long, complex shank. Remember, a simple shank is straight, and a complex shank has elbows and bends on them. Excellent for both anterior and posterior teeth. It's considered a universal because you can use it in both anterior and posterior. What are some of the disadvantages? None. So when you're seeing patients, you'll see the instructor pick up this instrument instead of the anterior instrument and use this all over the mouth, because it can be used all over the mouth. And you'll learn how to do this, use this in the anterior area next year. We just don't want to confuse things because it involves flipping an instrument where you normally don't flip the instrument. But the curved back of the working end touches the soft tissue. Okay, we don't want to be poking the gums, all right? The complex shank, all those elbows and bends makes it easy to reach. You can use it in shallow sulci as well as deep pockets. So strokes have different names. One of them is an assessment stroke, another one is a working stroke, and an assessment stroke is used to assess your detecting. You're detecting calculus deposits, you're determining if the tooth has any surface irregularities, and that's called an exploratory stroke. You're not using it to do anything except assess and detect. An assessment stroke is also called an exploratory stroke. During subgingival instrumentation, you have to rely on your sense of touch to locate the calculus that's beneath the gingival margin. And that's where we're spending most of our time, my friends, is underneath the gingival margin. So we have to develop this tactile sensitivity. And tactile sensitivity is the ability to detect tooth irregularities, which includes calculus deposit, by feeling the vibrations transferred from the explorer tip to the instrument shank and the handle. So we're feeling all of that. We develop tactile sensitivity the more experience we get. The explorer tip quivers as it passes over the calculus deposit, and the vibrations are then transmitted to the tip through the instrument shank and handle. The clinician then feels the vibrations with the fingers, and then we can recognize what these vibrations mean. Is it a pothole? Is it, does it come out from the root? Does it sink in? Is it rough? Is it smooth? Assessment strokes should be short in length and involve many overlapping strokes. So just like the probe, you don't want to skip any areas underneath the gum tissue. Right? You want to feel everything. So this is very similar to the probe, right? The same type of stroke, only with the probe, you saw it kind of go in a little circle, half circle. You're doing the same thing with the probe, and notice, or this explorer, notice that with this, if the gum tissue was here, they're not exploring the entire subgingival area. They're making zones out of it. Techniques for exploring your grasp is light, relaxed, adaptation, the tip, side tip, 1 to 2 millimeters. Lateral pressure should be feather light pressure against the tooth. Feather light, you're not pressing hard, you're feeling, and the stroke should be fluid and sweeping and light. You want to avoid that death grip, and when you're nervous and doing it for the first time, you are gripping that instrument too tightly. You avoid applying pressure with the middle finger against the shank, okay, because what that's going to do is reduce your tactile information that your fingers are receiving. You don't want to remove the explorer from the tip. Each time you go up and down the sulcus, you want to keep it underneath the gingival margin, just as you do with the probe. So it's going to take some practice to get those fine motor skills developed. Removing and inserting the tip repeatedly can injure the gingival tissue, just as it can with the periodontal probe. So you want to keep that side tip in contact with the root surface as you move across the tooth. You keep the stroke short, only about 2 to 3 millimeters in length. So if you've got a very deep pocket, you're dividing that pocket up into the bottom half and the top half. Okay, you're dividing it up. Make many overlapping multi-directional strokes to assess the entire root of the tooth. So it's not just going up and down. You're going up and down, you're going back and forth, which is a horizontal stroke. You're going obliquely. You always, with instrumentation, you always go in the direction of the tip. The tip leads. So the explorer tip is going to go in the direction that you're moving, just like your instruments, your scalers and curettes. You're moving in the direction of the tip. So again, your assessment stroke is very light, It's used to detect calculus deposits. You're using your tactile sensitivity. Those vibrations are going to be transferred from the tip of the instrument to the handle, and you're going to interpret. So let's take a look at your two Explorer types. This is the Orban style for number 17. Eventually you will know the name as well as the number of the instrument. You identify the tip and the lower shank of the Explorer. The book calls this the get ready zone because you don't want to just plop that right underneath the gum tissue. You go around the cervical third and you place the tip on the tooth, and then you help that guide down underneath the gum tissue. You slide the tip along the tooth surface gently, and you make a series of feather-like strokes across the facial surface. This is the lower shank. Look how parallel that is in comparison to the tooth. It's parallel. Now, this is the part where you have to really roll your instrument because you've got this going this way. If you don't roll this around this corner, this tip is going to poke into the gum tissue. So you want to roll the instrument. And you explore the interproximal. You continue making strokes until you have explored at least halfway across the mesial. Again, because you're going halfway across the facial and halfway across from the lingual side to reach that entire portion of the interproximal. So for exploring, it's good to do surfaces towards you and surfaces away from you. So you explore all the surfaces towards you first and then all the surfaces away from you. Because you're going to be seated in different directions. So this is your ODU, your 11-12. This portion is the lower shank here, and this is your working end. So you're going to be looking at the lower shank, but then you've got this bend here and these angles. You're only placing that terminal 2 millimeters of the side tip against the tooth. For anterior, you can see how nicely it rolls around. It wraps around the tooth. This would be the wrong end. And we're not using this for the anterior teeth this semester. So your ODU, know where your lower shank is and your tip. You need to select the working end to observe the relationship of the lower shank to the distal surface of a premolar tooth. So with this, we tell you just to slip this instrument between two teeth. It's going to be super gingival, and you're going to take a look at it. And we use the premolar because you don't need to retract or anything. Everybody can see where the premolar teeth is. So you just slip the instrument between two teeth. Is this functional shank up and over? Is the lower shank parallel? So we're looking for parallel lower shank, up and over functional shank. Or does that lower shank go down and around? Is it wrapping around the tooth? All right, this is the wrong direction, the wrong end. Can you see the difference? Up and over and parallel versus down and around. Functional shank is up and over, posterior is parallel. So you're going to start on the distal facial, say, of posterior, the most posterior tooth, and you, just like you're probing, you're going to be walking to the distal, then you take the instrument out and you just roll it so it's facing this way to do the rest of the tooth. Get ready zone. You're going interproximal. Feather-like strokes. Then you take the instrument out, you roll it to have the tip facing the other way. This tip is facing the direction it's moving towards. You insert, okay, so this is placing, look at the instrument here, it's kind of laying down a little bit. So you're going to introduce it underneath the gum tissue, and then you're going to bring this instrument up to straighten it up. And then you walk it around all the way to the mesial. So you'll be doing one tooth, distal line angle distally, take it out, roll it, go around distal line angle all the way this way. Then you place it in the distal line angle in the tooth in front, do it distally, come this way. So can you see the sequence right there? For the maxillary, it's the same thing. You've just got more things to work around. Okay, this is that palatal root. So you have to know the anatomy to know where you're trying to feel. But the sequence is the same. So we're using these explorers to help us detect calculus. Now, do we use explorers all the time when we're scaling? No. We are going to be using and getting to know our probes when we're in private practice. We're probing every patient, and that is our calculus detection at the same time. If I'm doing specialized treatment on a patient, I will use an explorer if there's an area I think that I have a question on, but your tactile sensitivity is going to get very good by the time you graduate. So we need to be able to detect calculus, and where hygienists generally miss are at the line angles of posterior teeth and at the midlines of anterior teeth. So calculus deposit at the line angle and midline areas of the anterior teeth can be detected most easily by using something called a horizontal stroke. So just like your fibers, your stroke is the same thing. So the stroke, instead of going up and down and oblique this way, a horizontal stroke is just bringing it across this way, perpendicular to the long axis. Horizontal stroke. So we're using different stroke patterns to make sure that we're getting everything and feeling everything. So you can see that this is not parallel to the long axis, but the instrument stroke is going this way instead of this way. Horizontal stroke around line angles. Anterior teeth. Now you can see that this is using that little tip here that's at that 90 degree. You're using a horizontal stroke. This will only work if you have a 2 or 3 millimeter sulcus. If they've got a 9 millimeter pocket, guess what? The tip ends here. You're not going to be able to reach down 9 millimeters. Horizontal strokes are used to detect deposits on the line angles of posterior teeth and the midline of anterior teeth. Test question, my friends. Positioning errors. We haven't really even done a lot with the probe yet, but it's very difficult to maintain a neutral wrist position. You're going to be bending and cocking, and we're going to be saying, stop, take a look at your wrist, what's your grasp look like? And that is just going to take some practice. So again, this is where having your book in clinic can help you. Okay, incorrect handle position. Look at her thumb here. It's not even a soft C. This is the handle rest is incorrect. It's resting on her entire forefinger here. That's what we want you to look like. So for the anterior, remember your clock positions. She's sitting in the 9 o'clock position to do the surfaces away. Look at this wrist. Is she doing it? Yeah, she's doing it, but she's sitting in the 8 or 9. Look at the wrist versus if she was in the 12 o'clock position. Can you see the difference? So it's all a matter of trying to verbalize what you're feeling as well. Hygienists love the word spicule. You left a spicule, and by the time you graduate, you're going to say spicule this and just, you know, you hate it because you've left spicules behind. But those are just little pieces, okay, of scattered deposit. Then you can have a ledge, a ring, or a veneer of calculus. So when you're, again, describing the deposits that the patient has, you want to be using these words. Normal, it's going to be somewhat smooth, okay? You might feel the CEJ. For calculus deposits, you're going to feel these little bumps. Pieces of gravel. A ledge is more like a speed bump. Overhanging restoration. You're going to be able to feel that. And you'll be able to feel that too. Defective margin of a restoration. This is a pothole, okay? We're using air to help us detect calculus. We're using transillumination to help us detect calculus for supragingival. So for dental caries, this is what an Explorer is used for too, and you're going to be doing a hard tissue exam on all of your patients, hard and soft tissue. So let's take a look at cavitated versus non-cavitated lesions. Cavitated lesion is a loss of the outer surface layer of the crown or root surface, usually needing a restoration. A non-cavitated lesion is a result of demineralization of an area of tooth. That non-cavitated lesion is oftentimes reversible or can be arrested with treatment. So we are no longer having watches just placed on teeth. Oh, let's watch the mesial of this and the distal of that because it's beginning to be a cavity. If we're watching it, that means we're going to wait for it to decay. We now have the capability of arresting, halting, arresting, and reversing. So it's important to identify the disease process early in order to halt the progression of this caries process. So early detection is imperative. So we're using light, we're using air, we're using clinical judgment. We are not using our Explorer to poke into these lesions because we just make it worse. If it is a non-cavitated lesion and we use our Explorer and break that surface in any way, that area then will not be able to remineralize. So the Explorers that we used to use extensively are really not as reliable as we like them to be because firm pressure can actually interfere with the remineralization. I don't need to poke this to know that it's a cavity. I need a radiograph. So offices have a lot of different ways to help detect dental decay. Visual detection is one, radiographs is another, laser fluorescence using something like, or an electrical caries measurement, like a diagonodent, one of those other machines that can help tell the dentist where there is a change in mineralization of the tooth. So we want to try and find things early. So we're almost done. Does this look correct or incorrect?
Incorrect.
Why?
It's going down and around instead of up and over.
Woohoo! Down and around and not up and over. What's that look like? I'm saying this is going to look pretty good. My only complaint with this, okay, is that this is so parallel, it looks like that the tip might be off the tooth. So this really should be angled just out just a little bit more, kind of like your probe. Different probe readings. So this is 4 and 5 here, so that the book wants you to do is say that this is 5, 6, 7, 8 millimeters is what they want you to do. So you have to know your probes, and it's important that each operatory have the same probe so everybody's reading the same way. You might be reading up more, rounding up versus rounding down. That's why we give ourselves that plus or minus cushion of 1 millimeter. So if Jonathan is telling me he's getting 3, 2, 3, and I'm getting a 2, 4, whatever, as long as it's plus or minus 1 millimeter, it's still okay. So even from one time you do it and you do it again, it's that plus or minus 1 millimeter. If it was 2 millimeters, that we consider to be a change. So this is your probe here. It's not even up to the 1 millimeter, is it? Very shallow. Okay. Are there questions? Because we're done.
I have a question, not related to the lecture today, but for week 6, I don't see that we have any of the Wilkins chapters to read. So for navigate for that week, what will we do?
Nothing.
Nothing. Okay. Okay.
I just habitually went through and put navigate for the appropriate chapters or whatever. Yeah, if there's no Wilkins, then there's no navigate.
Okay, and then from here on out, do you want us to actually do the reading and the navigate quizzes before the lecture of that week, or are we still gonna go back to doing the quizzes?
I need to change that. I will allow you a week to get it done because I know you've got a lot on your plates.
Okay, thank you.
Yeah, so I need to change week 5.
So we don't have the chapters yet. We don't know what chapters exactly are going to be on the exam, next exam, right?
Right. It could be all of them or some of them.
Okay.
Any other questions? I'll be on campus tomorrow, like 9 to 3 or something. I'll be in local anesthesia lab. So if I'm in my office, feel free to come in if you've got anything to discuss or just to say hi. I have chocolate. You can take a piece of candy up on. So feel free to say hi. Any other questions?
Yes, I do. From just to go back from what possibly may be the chapters for the exam, it may possibly be just possibly like 5, 7, 13, and 18, and then the navigates. I'm sorry, the
and then Gehrig.
The Gehrig. So 5, 7, 13, 18 from Wilkins, and then the Gehrig modules. That we okay.
Are we good?
When will we know what chapters are going to be on the exam, Miss D?
When I make up the test.
Okay.
I'm sorry. I don't have it yet.
Misty, just have a quick question. So when is the best time that we can reach the tutor for the next test? I don't know that they are ready first to.
They are, I got communication with Emily, who is the coordination of the tutoring center. We were in communication yesterday. She wanted to know what your class times were and clinic times and everything. So she's putting together a schedule.
Okay. So whenever we need to make an appointment with the tutor, we have to contact with Emily first. Is that right?
I think there's a computer where you make them through the computer. That's how they did it in the last couple of years, to the tutoring center or whatever on your MyNova and sign up that way.
Okay.
That's all I know. We've got, she's new this year and she's changing things. So it's you're just as clueless as I am. However, the students have all said they're very willing to help you. Not going to get paid. So reach out to your big, reach out to somebody that can help.
Sure. All right. Thank you.
Because I think about 10 of them said they would volunteer. They feel your pain. Any other questions? Okay. Well, have a good rest of the day, guys. We'll see you tomorrow.
Bye.